Good morning, ladies and gentlemen. First, I would like to acknowledge to Professor Topolchan that one more time he invited to be here with all you. I hope that he will be happy with the conference. Like always, I will try to be provocative, okay? But it's not really provocative because it's the normal work that we are doing. Well, what means that? I will try to show that this point, when we speak that tumor markers are not useful for diagnosis, this is not my opinion. I think that tumor markers are useful for diagnosis. And I will try to show that. I think that we need to broken the barrier that tell that. And like my friend Isaac Asimov told, try to do new things that help the people, help the doctor, and help the patients. Well, why? Evidently, I am not speaking to do today with the knowledge that we have early diagnosis. I am doing in lung cancer. I am doing screening in ovarian cancer, but not in the majority of tumors. But in our hospital, we have around 20% of patients that arrive the first time with advanced diseases. We can help in them. And also, we have some patients that, after all the techniques that we are able to do, we don't know where the cancer is. We call cancer of unknown primary site. Well, we can also help in them. And this is very important, so important that some internal medicine people make a new units they call quick diagnosis unit, trying to help, trying to make the diagnosis earlier in these patients, trying to do it more efficiently and in less time. Well, I am speaking about these patients, not in the screening. Well, and I will do no magic, I will do science. Why? I will use, was the first time that I published it in Tumor Biology some years ago in a high number of patients. This study is totally prospective. It's my normal work every day. It's the same in lung, in ovarian, but in this group of patients, it's my normal work. And after that, we published in several journals, like this one, like Chemical Clinical Acta, like Clinical Chemistry, better journals, and also now in this that suggests the use of marker for early diagnosis of lung cancer. Well, in summary, I have experience of more than 20,000 patients, and I will show you my experience in the clinical practice. And to avoid errors, I am not trying to use the normal cutoff. In diagnosis, you cannot use always the normal cutoff. Why? Because the cutoff changes according to the patient situation. It's not the same a patient with renal failure, a patient with jaundice, a patient a smoker, that others that are not a smoker without jaundice or without renal failure. For that reason, I think that we need to adapt our cutoff to the patient situation. This is very important. If not, you will make mistakes. Second, in some cases, you need to use a second cut point because the first is not useful. For example, pro-GRP in patients with renal failure, you need to use a higher value. Why? Because patients with renal failure are with a normal pro-GRP. And always you have doubts. What is the best system with tumor marker to be sure that it's a cancer or not? Serial determination. Repeat the sample in 3-4 weeks. Okay, we will see it. And evidently, there is not only one marker that is good. Evidently, you need to use a panel of markers in relation with the tumor that you are looking for. Okay, these are my criteria. It's published, I can give you. You will see them in all the conference. For example, CA-125. To be sure that it's cancer, I need to find levels higher than 300. With this, the probability of cancer is 98%. But if the patient is with liver diseases or pleural effusion, to be sure that it's cancer, I need 500. And if the patient is with ascites, to be sure, with 98% of probability that it's cancer, need to be 900. And you see that the level of the marker, the criteria change according to the patient situation. For example, S100. Never use S100 in those patients with renal failure. because will be a false positive. These are my criteria, okay? And I studied in the last 12 years, arrived to my hospital, 4,601 patients with suspicious sign of cancer. And the final diagnosis was no cancer, other disease. You can see them here. In these patients, I am able to study the specificity, because this is prospective. How many of them I suggest cancer? You will see here in this slide. The criteria for alpha-fetoprotein are correct in the majority of cases, like the majority of tumor markers. This is not a study, it's the normal work every day. And look, 3 times more patients and the same results that in 2012 with 2,700 patients. But well, the specificity is really 99, no. Why? Because some patients are with a normal alpha-fetoprotein, others will be with a normal PSA, others will be with a normal CA. The real specificity is 97%. In 3% of the patients, I made the mistake to suggest cancer that finally is not there. No one is perfect, okay? Well, but there are important points. For example, when there are 2 markers that clearly suggest cancer, in 2,500 patients with cancer, 99% of them were with cancer. In summary, the system worked with a very high specificity. And I will want to show you some examples. A woman, 78 years old, with renal failure, that was treated of endometrial cancer some years ago, now is no evidence of disease, and the doctor sent her because he is worried. And we found abnormal HE4. What means? Is a recurrence? Is a second malignancy? It's nothing, because the patient is with renal failure. And you cannot use HE4 in patients with renal failure. For the reason our comment was that the patient is with low risk of cancer. And I explained to the doctor that HE4 cannot be used in women with renal failure. Look, if the doctor thinks that this is a cancer, the opinion of tumor marker will be terrible. Markers are not useful. You tell, don't worry, this is normal. And the patient is with normal things, without cancer. The doctor will believe in tumor marker. For this is very important that we put our comments, our suggestions. We are experts in tumor markers. Okay, you can see here other patients. This is our algorithm, our program to do it. Male, 56 years old, a smoker, that came with pemphigus. The reason that the doctor asked, because sometimes these dermatological diseases suggest cancer. Look, all the markers normal. You can see here always the cut points, okay? To suggest cancer with a high probability. Well, if it's normal, for us it's not cancer. I'm sorry, we found abnormal SCC. Is cancer? No, why? Because pemphigus increases the levels of SCC. For the reason we need to tell the patient, low risk, but also take care, because psoriasis increases SCC. SCC cannot be used in these patients. Other time, the results suggest cancer. If we don't tell anything to the doctor will make a mistake. Okay? Well, this was in relation with the specificity. In relation with the sensitivity, this time we studied 2,564 patients. Some of them are non-epithelial tumor. We know that these tumors don't release markers. Why I studied them? Because it's prospective. I don't know the diagnosis until 2 weeks later. And I include here all the patients studied. 417 of them were also these unknown primary malignancy cancers. Sensitivity, 65. What means? In 3 hours, I tell to the doctor that this patient is with epithelial malignancy. 65, I will prefer 100. But if we take out those that don't release because are not epithelial, results improve. We are able to tell the diagnosis with a 97% of the specificity in 3 hours. And evidently, if they are with metastasis more, that they are without it. These are locally advanced, no early diagnosis, okay? Well, I will explain some cases. For example, a female, 80 years old, that arrived with wasting syndrome and abdominal mass, evidently with ascites. And we have abnormal CA125. Abnormal? This is normal in a patient with ascites. Okay, I have slightly high cipher, normal in a patient with ascites. But I have very high levels of AG4. Very high in relation with the suspicious point. And for the reason, the common is high probability of malignancy and high probability of gynecological cancer, mainly ovarian cancer. And this was the diagnosis. And this is the thing that I am able to do every day. I have around 10 patients of this group, other similar in lung and other diseases, okay? You can see here other patient, female, ex-smoker, 56, wasting syndrome. This is a very frequent paraneoplastic syndrome. Okay? Marker, well, you find high level of cipher. Without renal failure, this indicates cancer. I am sure that is cancer. Find abnormal NOAs. Look, the patient was treated for escamose, and the doctor wants to know, first, is cancer. Second, is a recurrence. Third, is other tumor. Do you know any tumor escamose that releases NOAs? Not. For this reason, we can tell easily and in a few hours that this is not a recurrence. This is a second malignancy. Okay? And also abnormal CA. All three suggest cancer. The probability of cancer is 100%. Okay? We suggest with this marker mainly high risk of cancer, but mainly neuroendocrine tumor, and was a final diagnosis. And this is the thing that we are doing with the criteria published in 2017, 12, and now that we send to publish, and I hope that will be published before the end of this year. But we can do more things. For example, it's very important to distinguish epithelial and non-epithelial tumors. Are markers able to do that? Well, look, this is the sensitivity, the proportion of patients with abnormal, according to my criteria, markers in around 400 patients with non-epithelial tumor. Look, the majority of tumors are negative. You find in a patient abnormal CA, it's because it's not mesenchymal, it's not a leukemia, it's epithelial tumor. And you are sure in 3 hours. Well, NOA sometimes is positive. I don't know why we are evaluating this point. I hope that the next conference I will be able to answer. But cipher is negative, only in mesotheliomas. In the other are negative. In summary, it's very useful. For example, here, you can find a woman, 77 years, that arrived with bone pain and some bone image. All the markers are negative. Look, all the markers are negative. Well, for me, this is not a cancer. And I put, no, epithelial cancer. Okay? And it was a sarcoma. Markers are only useful in epithelial tumors. Okay, you can see here other case, female, 68, arrived with the same, wasting syndrome, also with lymphadenopathy. Only a small increase of CA125. For me, to high risk is more than 300. This is negative. Summary, all the markers negative. It's not epithelial tumor. We explained that they need to be careful with effusions, and it was a lymphoma. Well, and I learned a lot with this protocol. For example, neurology. They were asking me tumor marker, and I told, well, why you are asking me about tumor marker when your tumor, brain tumor, don't release the marker? And I explained clearly, well, primary tumors don't release, but the majority of metastatic tumors release. You are able to tell me in 3 hours if it's metastatic or primary. If the markers are high, high probability of metastatic. If the markers are negative, high probability of local primary tumor there. And this is very important for me, and you are doing in 3 hours. Well, some examples. Female, 75, arrived with a mass in the central nervous system. Evidently, always I determine the creatinine, all the markers negative, a big mass in the brain. If it's metastatic, the probability that all markers are negative is very low. For the reason we suggest. Low risk, never negative, because there are tumors that don't release tumor markers. Okay, and the final diagnosis was with glioblastoma, a primary tumor. You can see here other patient, male, 59 years old, smoking, that arrived with headache and also with a mass in the same place. But look now, 358 of CA. Look, it's clear that it's a cancer. I don't need anything more. I can tell only in half an hour to the clinician that this is a patient with cancer. I don't need anything more. Okay? But also CA53 is 235. The same, sorry, is 100 here. Okay, it's the same. With only one of these markers, I am able to tell him that it's cancer. Remember, when 2 markers are suggestive, the probability is 99.8. I am able to tell the doctor in 1 hour, look, this male is with a probability of 99.8% that to have epithelial tumor. The mass is not original there. It's not a tumor, a primary tumor from the central nervous system. Sorry? And it's the thing that I told, 99.9% of probability of malignancy. The majority of probabilities are non-small. Sometimes pancreatic, when it's always negative, and this is not the case, and was a lung adenocarcinoma. And I have 2,500 patients like this one. In summary, until now, I showed you that we are able to suggest cancer with a very high specificity, mainly if we use a serial determination in those cases with depths. If CA is 100, you don't need to repeat, it's cancer, okay? With a high sensitivity, and also we are able to distinguish epithelial and not epithelial. Now the question is we can use to distinguish some paraneoplastic syndrome. A patient with jaundice may be benign or malignant. A patient with bone pain can be benign or malignant. A patient with ovarian mass or abdominal mass can be benign or malignant. Are tumor markers helping in that point? And I will show you some examples. Male, 82 years old with some problems in the bone. All the markers negative. Well, low risk and was a benign disease. 3 hours. Here the same male, 58 years old, a smoker, the same clinical points, but now it's a patient with, well, more or less abnormal progeria, but 57 is very small. Okay? CA of 33. This is clear cancer. I don't need anything more. With this, I am sure with 99% of probability that it's cancer. I don't need anything more. SCC of 9.2. If there are not renal failure and there are not any dermatological disease, it's cancer. And with SCC, I will look mainly for squamous tumor. Not small, but mainly squamous tumor. And it was squamous lung cancer with bone metastasis. Very easy. If you follow the article or use the program. Well, you can see here other case. Female, 55, with chronic liver diseases. Always I determine the enzymes. Why? Because the criteria are different. It's not the same a patient with liver diseases that a patient without it. You cannot use the marker in the same way. The same, always jaundice, Watson syndrome. All the marker, well, a small increase of cipher, normal in patients with liver diseases. A small increase of CA-125, normal in patients with liver diseases. A small increase of CA-53, normal in patients with liver diseases. Only when it's higher than 100 will be suspicious of cancer in a patient with chronic diseases. For me, this is a normal patient, a patient with low risk of cancer. And this was the thing that I told, the low risk. And also, if you have that, I offer always the option to the doctor, if he wants to be totally sure, he can repeat in 3 weeks. But in this case, it's clear that we can explain all the data. And it was benign. Here, other men that was previously with prostatic cancer, now in theory without evidence of disease. Only with this, I don't need anything more. This is the levels of CA-19 in this man when he arrived to the hospital. This is sure that it's cancer. I don't need anything more. But CA is also totally clear that it's a cancer. You can remember the points. Well, this one, more or less, but these two are the most important. This can indicate liver problems that are there. In summary, we suggest a high probability of malignancy, mainly pancreatic cancer. In some cases, can be also gastric, but with so high levels, habitually are pancreatic tumor. And this was the diagnosis. Both were with jaundice. Both at risk with cholestasis. But marker clearly show you in 4 hours the difference between them. In summary, and answering the question, are tumor markers able to suggest, to help, not always, but in the majority of situations, different diagnosis, differential diagnosis? The answer is yes. And we are arriving to the last part of this talk. Can we suggest where the tumor is, the tumor origin? This is more difficult in some situations. In some, it's very easy. For example, this male, 76-year smoker, that came with bone pain. Well, PSA is 211. The clue is very clear. I will check, excluding prostatitis, with these high levels, that the probability of cancer is very high. And the location, evidently, with 211 of PSA, the probability of prostatic cancer is very high. Very easy in this case. And this was the diagnosis. In other cases, for example, this is a male that was treated before of a melanoma, but now is without active disease, in theory is cured, and arrived with abnormal NOAs. 1/3 of the patients with this diagnosis are with abnormal NOAs, and very high levels of S100. If there are not renal failure, this is melanoma. Both suggest together melanoma. In summary, is the probability of cancer and the probability of melanoma. This is also very easy. It's in the publication, okay? Well, but not always is so easy. For example, alpha-fetoprotein is specific. I know that it's in all the guidelines about testicular cancer, but it's not specific of testicular cancer. It can be found in gastric cancer. 10% of gastric cancer release high levels of alpha-fetoprotein. Or neuroendocrine tumor. 25% of neuroendocrine tumor release alpha-fetoprotein. Evidently, liver cancer and testicular cancer. Well, what can we do? A ratio. What is the markers that are the best, the predominant marker? And this will tell you the answer. Or CA-53. Until a few years ago, all the publications suggest that CA-53 is a marker for breast. And it's true. But it's a marker for non-small cell lung cancer. It's a marker that can be found in ovarian cancer, in endometrial cancer, in gastric cancer, in pancreatic cancer. It's a very good marker for breast, but it's not only in breast. With abnormal CA-53 alone, you cannot be sure that it's a breast cancer. Evidently, it's a woman with breast cancer, and they told that it's breast cancer, you will follow that. But with only the marker, you cannot be sure. all these diagnoses are possible. In summary, it's not so easy. We make, or we look for new markers, for example, in every one of these malignancies, in breast, HER2-neu, or we try to make ratios. For example, male smoker came with a lung mass. Look the pro-GRP, very high. I know that in NOAs, very high. I know that NOAs can be in lymphomas, can be in a lot of tumor, but pro-GRP not. Only looking the pro-GRP, you are sure of the diagnosis. And this clearly, these high levels of pro-GRP indicate sure that it's a cancer. And with these high levels, not only the probability, but also it's a small cell. That was the final diagnosis. One system looked for new markers. I know that NOAs is not so specific. Use pro-GRP. Or other case here, a male, 56 years old, with chronic liver diseases. Alpha-fetoprotein was 122. Only with this, the probability of cancer is very high. Well, no neuroendocrine because NOAs is negative. If maybe testicular cancer, we cannot distinguish. But it's not gastric because all the markers habitually in gastric cancer are negative. For this reason, we will suggest mainly primary liver cancer. High probability of cancer, mainly primary liver cancer. That was the final diagnosis. Male, 45 years, abnormal cipher, but not very high. NOA is very high. This tells you that is something. Alpha-fetoprotein abnormal. What is? Liver or neuroendocrine? What is the marker higher? NOAs. For this reason, when the levels of the markers that are predominant is NOAs, we will suggest mainly neuroendocrine tumor. That was the final diagnosis. Some criteria, you need to know the criteria. But these criteria are very easy to do and follow. And with this, you are helping to the doctor. Well, to finish this, only 5 more. Not always it's so easy. For example, this man arrived 70 years old, is a patient with prostatic cancer and hormonotherapy. But the doctor is worried because the clinic don't seem prostatic. And he called me and said, well, are you sure that this patient is with something more or not? Can you tell me if it's a second tumor there? Well, I tested and I found abnormal CA15-3. This marker is not habitually found in prostatic cancer. CA, high levels of CA are very infrequent in prostatic cancer. And pro-GRP abnormal, well, more or less, this is not so high, but it's not frequent. This can be found, but not frequently in prostatic cancer. These two tell you that other tumors are there. And I suggest mainly lung. And the pathology don't know. He told that the patient with a second malignancy, that is adenocarcinoma, but he is not able to tell you where the origin is. He knows that it's a second malignancy, but no prostatic, but he is not able to tell you the origin. Well, we did. In summary, we are able to do that in 3 of every 4 patients. Evidently, in those with abnormal levels, we are able to suggest the origin in the majority of them. When I told suggest the origin is 1, 2 places. You see, I gave the result in proportion. 90% of prostatic cancer, 10% of gastric. I cannot tell you sure 100% in the majority of cases. And in the cases that we compare with the pathologies, the correlation is habitually very good. In a no-primary malignancy, the same. We are able to suggest the origin in the majority of cases, mainly if the markers are abnormal, and these are the tumors that we suggest in those cases that the pathology is not able to tell you. And to finish, only 5 slides. This is the publication that you will be able to see, I hope in 3 months, Or you are able to see, you check the tumor pathology of 2012, because the results are exactly the same, only with 4,000 patients less. Well, this is a program that we are using, made for my hospital. In 2014 of these patients, in 6 hours, we classified them in the majority of cases with epithelial cancer. 6 hours, very easy to do for all the people. Some cases, like always, to confirm, female, 56 years old. She had a breast cancer, but not active. Now, the doctor don't know, because the patient comes with thromboembolism, that for some people are paraneoplastic, and we found high levels of CA. This may be cancer of breast, or lung, or colorectal, or other place. But we have very high levels of H2-neo. This is only breast. So high, only breast. For this reason, we suggest that, and was the final diagnosis. Well, in other group of patients, 1,600, in 6 hours, we are able to tell them the probability of cancer is very, very low. You see in other cases, but female, 58 years, also with a breast cancer before, came with a sample with hemolysis, and you find high level of enolase. Is cancer or not? Sorry, you can see that it's not cancer because the sample is with hemolysis and you cannot use it. This is the way that we are using every day. And was a false positive image of the CT scan. In a group very small, less than 10% of the patients, we are not sure. We are not sure if it's cancer or not. And what is our suggestion in this group of patients? Repeat in 3 weeks. The serial determination that I suggest. And I will present 2 cases that are real and very surprising, okay? This is the first. It was not mine. Other hospitals sent me the patient 2 days before that this patient got to surgery. The idea was to do a gynecological ovarian and endometrial out, no surgery. She was a young woman, 52, but with a small problem. The levels of CA99 were very, very high, around 2,000. The gynecologist was worried and sent to other gynecologists. They made the evaluation and all this, and they were worried because with these high levels, the probability of cancer is very high. They sent me the patient with 3 serial marker determination, 2 exactly. These 2. Initially it was 2,654. 3 weeks later, 2,554. And in my hospital, 2,309. Very high. But with this, I told her, please don't go to the surgery. You don't need the surgery. This is not cancer. I don't know what is, but cancer not. We did all things that we are able to do. Serial dilution, looking for some antibodies that react. We didn't find anything. But the patient last month was still with ovarian, with endometrial, without anything. 7 years later, and still is with a very high levels of CA99 and without nothing. I have around 10 patients at this one. In summary, when you have dots, please do follow up. A tumor go up, never go down, or in the same level. Serial determination is the best system to know what happened with the tumor markers. And the second is this man, 49, a smoker, that arrived to the hospital with a lung mass. CT scan tell that it's not very clear, but for them it's not cancer, but I found slightly high levels. I cannot tell that it's cancer. I am not sure. And what is the thing that I do in these cases? Repeating 1 month. Okay, I ordered to do it. I told them, please confirm in 3-4 weeks. Well, the patient arrived, and 4 weeks later, exactly 6 weeks later, the patient was with significantly higher values. CT scan tell that for them, no change, no risk. Well, not always CT scan is correct. And we found lung adenocarcinoma, and the patient was treated by surgery. Habitually, the best system is CT scan. I am not trying to change that, but in some cases, we can help. In summary, and to finish, using this program, we are able to have a sensitivity of around 76%, with a high specificity, with a high positive predictive value, and, well, the negative predictive value is not so good, but it's not bad, around 90%. In conclusion, to do and to obtain good results, you never need to be alone. You need to work as a team with all the doctors that need, and with the patient, need the results. Thank you very much for your conclusion. This is my group that really are those that are doing the job. Thank you very much.